Hi, this is Roger Green, host of the Suffering the MASH Tsunami podcast. This week we're offering 5 conversations from episode 22, our discussion on the Healthy Livers, Healthy Lives Coalition, stemming from a presentation at the EASL Congress, joined by Jörn Schattenberg, Louise, Campbell, and Coalition Chair Jeff Lazarus. From the vault, we have a discussion from 2023, how regulators and some providers hear and process patients' needs. This conversation focuses on the interplay of individual patient needs and public pressure/public policy. It starts with Louise returning to the issue of primary care. What she's observed in her work is the primary care providers are appreciative when specialist nurses can talk with physicians about the target patient, test protocols, ways to find the right patient population, in other words, not just looking for heavy drinkers, and broadening discussions in this way. Jeff points out that this is a valuable way to look at the challenge, but a holistic solution needs to translate individual solutions and individual patient management into systemic solutions like integrated care. Paradoxically, and I'm quoting here, one good thing here is that most patients with MASLD and virtually all with advanced MASH will have other medical conditions that require involvement from other medical and behavioral specialties. This relates to the idea of multidisciplinary care, which Jeff notes is easier said than done. However, once we can start to implement it through will and solutions, we can solve big problems and start to make faster progress. To Jeff, the other issue, as he puts it, involves systems approaches. He cites a New York Times article about junk food and the importance of funding package labeling. This is particularly key in poor and marginalized populations, and the doctors who treat these patients can play a major role as public advocates for their patients by writing letters to the editor of newspapers, medical societies, members of Congress, etc. By pressing the system, we can start to provide top-down policy that supports bottom-up patient management and improvement. As the conversation winds down, I go back to Jeff's earlier comment about how easy it is to get a FIB-4 and note that several of our patient advocates from ex-US countries have pointed out that an ALT test is not standard in their countries. Jeff agrees this is a point of stress where it does not already exist. We don't talk about public policy and MASLD very much on this podcast, except when somebody named Jeff, usually Lazarus, sometimes McIntyre, is with us, or when we're discussing regulatory decisions. This conversation moves fast and covers a broad range of issues, so just sit back, listen, learn, absorb. When you're done, join the conversation in our LinkedIn discussion group.
Louise Campbell.
Just to go in on the primary care, they do have an awful lot to do. And we're going into primary care areas at the moment. But what they've really taken to is the specialist knowledge of those nurses, going in and being able to talk to them about livers, being able to talk to them about what we're looking for, what we're finding, and how it relates to their practice, and to look in the not routine areas of alcohol and that, and opening up that discussion. And all of the patients so far have really been accepting of, I might not have the best social environment, I might not have the best green space environment, but how can I make small changes that can make a difference to my liver health? That's really important at primary care level, because not every patient is going to need to be seen by a hepatologist. Some are going to go to endocrinology, cardiology, and I think on the new combined guidelines and clinical practice for MASLD, there was a suggestion that if their CAP is very high but their fibrosis is actually quite low, that you review them in a year's time. So again, that discussing that management that they can do in the community by putting in people with knowledge, because it's better to do that, I always find, than to try and spend years upskilling, because they try to upskill in so much. It's certainly a very good one.
Jeffrey Lazarus.
But Louise, I think we're looking at like these individual cases. And so each time we do need to think about the individual management. But if we're really going to change things in the field, this is where the innovations come, like integrated care. If that person has an alcohol issue, it's not just the hepatologist they need to see. They need to see addiction specialists, addiction management, addiction centers. If the person has an eating disorder, it's not just the hepatologist. It's obesity management specialists, it's nutritionists and dietitians. So I don't want to say it's the good thing about MASLD, but the good thing is they're probably going to have something else, and you're going to have some kind of team care, which means that it's not all on the hepatologist. It's on the endocrinologist, the addiction specialist, the obesity management specialist, the primary care doctor, maybe the cardiologist, and others to find those solutions. So it means that for every person you get into the hepatology department, if they don't have advanced fibrosis and need your specialist care, there's another place in the system for them to get that care. And even if they do need your care, there's still another place, most likely, where they're going to need care, because there's a pretty good chance they have diabetes or are overweight. and so on. So I think we need to think a lot more about integrated care, something we put forward in our review of multidisciplinary models of care. And it's easier said than done. It's easy for us to sit on this podcast and talk about everybody should collaborate. When you get down to the system, it's more complicated, but we need to be thinking about that. And so that's something the hepatologist can be looking at, is like, how do I do this? How do I handle reimbursement? Who's the lead healthcare provider on the team? And I think when we crack that nut, and some centers we'll start to see bigger and faster improvements in the field. The other issue we need to address, and you might say this is really hard for liver specialists, but HIV and others did it, is to think about the system, we're living in. And just yesterday, the New York Times had a really great article about junk food, about the importance of front of package labeling, about the targeted, what they call the aggressive marketing to poorer and marginalized populations of processed and ultra processed food. We can tell people all we want, what they should eat. And that's something we do try and do in healthcare centers. But we also have to start looking at the environment we live in. And doctors can make a huge difference if they start writing individually, in groups and as associations, op-eds, engaging with their health commissioners. For example, in New York City, we have a great health and visionary health commissioner who launched the Healthy NYC plan with a goal of increasing life expectancy for everyone in New York, reducing diabetes, so on and so forth. No mention of MASLD MASH. So we're engaging with him, but we need clinicians to engage, because when we start to get these top-down approaches, it'll help us. Because what you're describing is great, but it's very much a bottom-up approach. With you and Jörn, give an example of a single patient, probably an archetypal patient. So there's probably a lot of people like that. But how do we address this particular person? We need to look at some systemic changes at the same time. And there's no reason we can't change the system. Just look at a cigarette package. And remember, there was a time when countries didn't even report their ingredients, or didn't even tell you how much sugar or how many carbohydrates were in a particular serving. So things have changed, but we need, from the liver field, to identify what are the most important changes and work to change them much faster.
I think, wasn't there an article either in the New York Times or the Times about we should start to treat sugar like cigarettes in the way of it damaging health? There was.
That was a great message, wasn't it? Why do we not have warning labels on white sugar, on sugar we're adding, sugar packages, what we do on cigarettes, and look at the damage from adding sugar to food? It doesn't say never do it, but just people should be aware that there's damage. And I think this goes back again to something we benefited from greatly in the HIV field, which was harm reduction. So, it's about reducing the bodily harm. It's not necessarily abstinence, but it's people need to be aware, and most people really aren't, on the dangers of sugar, and be aware of how much sugar gets added to the sugar-sweetened beverages and pre-mixed coffee drinks and so on.
Roger Green.
So, Jeff, I think all that's great, and I think really important. We've identified on this podcast in the last couple of years a couple of impediments that I'm just curious if we're making progress on and how we're doing, or if that's something that's in your scope right now. You mentioned, for one thing, that anyone can get a FIB-4, but in fact, as recently as 8 or 9 months ago, panelists told us that in a whole bunch of countries, ALTs are not a standard test, that you have to ask for an ALT to get it, which would mean your colleague who said you have to check a box, you would, because you'd have to do something to get an ALT before you could compute a FIB-4. Is that something that y'all are looking into or making progress on, or is that not the issue it was?
Yeah, and that's absolutely right. So, I'm generalizing. I can't tell you that every health system in the world automatically is collecting ALT. A lot are, and for the ones that are, I think a FIB-4 should be calculated. And I've had some great discussions with people who have made some very cogent arguments as to why that shouldn't be the case. So that's my opinion, that's their opinion, and we need some unity in the field that where ALT, AST, and platelets are collected, a FIB-4 is going to be calculated, and your nurse practitioner or your doctor is going to know what that means and what a next step should be. Remember back in, say, the early 2000s, 2007, 8, 9, there were activists who said, don't test people for HIV if there's not treatment readily available. They were wrong, because you can prevent, and then you can also build a basis for greater advocacy for making treatment available. If people knew that they couldn't find out, they didn't have access to a very simple non-invasive test to know if they have fibrosis, because ALT isn't one of the tests that's automatically included in lab work, maybe that'll start to change. It's not that expensive to add ALT on. I'm not saying every health system will or can, but certainly the ones that do should calculate articulate that.
So we're in violent agreement on that, that everybody should be getting an ALT for exactly the reason that you say.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the reviews section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Next week, Louise will be moderating an episode about challenges in communication between patient and provider and its implications on other systems issues. I'll miss the taping, but cannot wait to hear what emerges. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.